In 2025, mastering the Outpatient Prospective Payment System, or OPPS, is essential for hospital and outpatient facility survival. Clean, compliant claims are the backbone of financial health. Errors mean audits, penalties, and lost revenue. OPPS groups services into ambulatory payment classifications, or APCs, each with a fixed rate, shifting financial risk to providers and demanding efficiency. Bundling is central. Related services are paid as a package, not individually. CMS is expanding what's bundled in 2025, so knowing what's included in an APC and what's not is critical. Bill for a package service and you'll get denied. Miss a separately payable service and you lose money. With margins tighter than ever, understanding OPPS rules is non-negotiable. The 2025 updates add complexity, making proactive education a must for every outpatient provider. Mastering these rules is the only way to secure full, fair reimbursement. To master OPPS, you must speak the language of status indicators, single-letter codes that dictate how each service is paid. For example, T means a significant procedure with payment reductions for multiples. S is significant but not discounted. Q1 signals conditional packaging. Let's see this in action. A Medicare patient has a screening colonoscopy, S indicator, and IV hydration, Q1 indicator, in the same visit. The Q1 code is bundled with the S procedure, so the hospital receives a single APC payment for the colonoscopy, covering all related services, including hydration. This means no separate payment for the IV fluids, supplies, or nursing time. Coders can't assume every procedure gets paid separately. They must analyze claims through OPPS status indicators. Misreading these codes leads to denials, lost revenue, and compliance risks. In 2025, with more services bundled, understanding these indicators is more important than ever. Every claim must be built with these rules in mind. Accurate coding is the frontline defense against costly mistakes. Sometimes two procedures in one session are truly separate, and that's where modifiers come in. Modifiers like 59 or the X-EPSU subset can override bundling, but only with clear, specific documentation. Improper modifier use is a top audit trigger and can mean big penalties. Only use a modifier if the medical record proves the services were distinct, different sites, times, or clinical reasons. For example, if IV hydration was given hours before a colonoscopy for an unrelated issue, a modifier might be justified, but only if documentation is airtight. The default is to bundle. The burden of proof is on the provider. Regular audits and staff training are essential to prevent misuse. In 2025, with CMS's advanced analytics, honest, accurate modifier use is more critical than ever. The 2025 OPPS brings major changes, especially the expansion of comprehensive APCs or C-APCs. More procedures and drugs are now bundled into single payments, so billing systems and charge masters must be updated to avoid denials. Perioperative drugs newly packaged for 2025 require close coordination between pharmacy, clinical, and billing teams. Site-neutral payment policies are phasing in, reducing payments for clinic visits at off-campus hospital departments. Hospitals must reassess the financial viability of these services and ensure billing reflects the correct place of service. Staying compliant means ongoing education, reviewing CMS rules, attending webinars, and training staff. The rules keep shifting, but proactive learning is the best defense. Check CMS and trusted sources regularly to stay ahead and secure your reimbursement.